Now, it's BoomerLife, lifestyle discussion designed to make your life more engaging, meaningful, and complete. Celebrating the baby boomer generation, this is BoomerLife on CIL 650.
Well, good evening, and welcome to Boomer Life here on CIL 650, and congratulations on having survived the Super Bowl. A pleasure to welcome a brand new guest to our program. Dr. Paul Zickler is with YesWellness.com. Dr. Zickler, welcome to Boomer Life, sir. It's good to meet you.
Glad to be here.
You have quite a story to tell. You have spent a great deal of time in British Columbia as an emergency room surgeon at one of the province's most active hospitals, New Westminster's Royal Columbia. Tell us your story.
Well, first of all, I'm not a surgeon, just an emergency physician.
Oh, okay.
So yeah, that was a long time ago, Stu. That was a very long time ago. We moved here in 72 and 3, where I interned at the Royal Columbia, as you said. And it was during that year, my first rotation actually was in the emergency department. And
talk about baptism by fire, really, huh?
That was really something.
Had you anticipated that?
Well, no, they give you the schedule when you get there. And
welcome, and here you go.
And so I remember my first day in the emergency department, actually. The emergency physician came and said, Zickler, he said, have you worked in the emergency department before? I said, no, I haven't. I've never set foot in the emergency department before. Oh, he said, that's really good, he said. Well, he said, have you sutured anybody? I said, no. He said, well, I want you to go in that suture room. There are two people ready to be sutured. I'm going to show you the first one, and then you do the next one. And I'm just shaking in my boots, and I'm watching every step, listening to every word he tells me while he's suturing this finger. How to hold the suture, how to put the suture needle into the suture holder, how to put the freezing in, how to put the stitch, how to tie the knot.
Right.
And I'm just zoned in because this is it. I got to do the next.
That's right. There's another finger, and you're going to be stitching that one up.
And I thought he was kidding, and sure enough, he said, "Okay, that's it." He said, "Meet Henry over here. He's got his finger and needs to be stitched. So you're stitching that. I'll come back and look at it at the end." And oh boy, I was just freaked out. But that's the way you learned. And the next day, or at the end of the day, he said, "And oh, by the way, Zick, tomorrow your partner that comes here tomorrow, you teach him how to suture."
Oh boy.
So that's how we learn.
So 12 hours on the job, and you too become an instructor.
Exactly.
Isn't that something? Is the life of an emergency room doc as busy as we imagine it to be, and certainly as medical television portrays it?
He is. It's a very exciting, it's a incredibly involved specialty. And at that time, you have to remember that there weren't really any emergency physicians. When I interned, there were GPs that were all the GPs were called to the emergency department. And then what happened? A few of the GPs said, "Well, listen, I'm just starting out. I'm going to just sit here and I'll take the calls that the GP says, listen, I'm too involved doing something else.
Sure.
Would you look after my patient?"
Right.
And that sort of developed so that there was 2 or 3 fellows that were doing that. And then during the time...
So basically they created their own job.
Exactly.
Interesting. Okay.
Exactly. And the times, of course, changed too, because more and more people were getting sicker acutely or getting involved in trauma and not being able to be looked at in the office. So it was starting to get more and more involved. And you remember the old days, I'm not sure if you remember, but the ambulance was just basically a station wagon with a stretcher in the back.
That's
and they just picked you up and threw you in there, and they had no training other than driver's training and first aid.
Right.
And so that's where we started. And the same for the emergency department. So those fellows that were interested in doing the emergency work got there be more and more, and finally they didn't do any more office practice and were basically there waiting for calls to look after the patients. And then the year I interned, they started recruiting some of the interns to actually work full-time in the emergency department as they got busier and busier, and more of the GPs said, listen, I'm just too busy doing all my office things, my hospital work.
Sure.
I'm going to just sign off to you.
So at what point did it become okay for hospitals to create and staff their own emergency departments?
Well, it wasn't sort of okay. It was basically the Department of General Practice just developed into having full-time staff in the emergency department. There were no specialists at that time. Emergency medicine was not a specialty. So there is a group of doctors. And so once they recruited several of us in our interning year, we formed a corps of about 8 guys. And we became the emergency physicians. And those 8 guys, as well as the 8 guys at Burnaby, as well as the 8 guys at VGH, at St. Paul's, all sort of developed along the same time and became the core of the whole specialty. And those people were really keen in developing emergency medicine as a specialty. And they were all played an integral part in developing the specialty of emergency medicine, where now it's a specialty. There's residency programs, and it's a full specialty. But at that time there wasn't, and we were the ones that created that.
So
specialty.
you're trailblazers in your own way.
Exactly.
Now, in its time, the Royal Columbian was a major trauma center for the Lower Mainland, and my understanding is it continues to be a focal point for traumatic injuries. From what part of Metro Vancouver? Because it doesn't cover all of it now, does it?
Yeah, they still are the referral trauma center for the Valley.
Okay, all right.
So everything in the Valley up to Hope.
So how long were you an emergency room physician?
Well, I was there for about 20 years.
And
the first 10 years were exceedingly exciting and fulfilling, and really because we sort of developed a specialty. We developed ambulance training. We developed paramedics. We were in on several of my colleagues were instrumental in getting helmet legislation, seatbelt legislation. We were the group that was sort of leading the way, and it was so exciting.
Well, I can imagine, how fulfilling it must have been in those days when you and your colleagues, for example, approached the provincial government with respect to seatbelt legislation. Common sense, of course, but it wasn't law in British Columbia. It was starting to be in other jurisdictions, but not ours. And who best to speak to the subject than the guys who pick up what's left of people who don't wear seatbelts in car accidents.
Exactly.
A pretty dramatic presentation, I can well imagine, back in the time.
Absolutely. Yeah. So you can, if you just take that example and 100-fold it, that was what the excitement was about the emergency department, the whole role of the emergency department, the people's mental attitude in terms of starting to use that as the place to go to if there's something wrong.
Right.
And all of a sudden the cuteness of healthcare became worse. I don't know if there's increased population, more accidents, more stress in people's lives where they're getting sicker, more mental health issues. All those things became, besides the trauma, became the crux of sort of what we're seeing in the emergency department.
And I suppose you were there for 20 years, long enough to be part of that exciting first wave that developed the actual calling of an emergency room physician, because when you started, there was no such job.
Exactly.
And now you've created this job, and I'm sure mentored more than a few young interns into the program. But when did you notice emergency rooms beginning to replace the GP? Was it just because you mentioned population increase? Did we suddenly hit a point where there were just not enough docs for all the new people showing up in Greater Vancouver?
Well, I think at that time there were still enough docs, but they were still really busy and dividing their time in the hospital, in their office, in the emergency department, and then as technology changed as well, every specialty, their acute problems had new technology that went along with it. And so, it was difficult to really stay at the forefront and be really knowledgeable about every acute situation in each of the specialties.
Right.
And so it became more and more clear that there had to be a certain group of people that's what they did. They became specialists in that acute phase of illness and trauma, of across the specialties. So they could manage the acute bleeding pregnant woman. They could manage the traffic victim head injury and fractures. They could look at the person with an acute infection. He's very sick. They could look at the acute psychiatric problem and deal with that. So there was those acute situations in every specialty that he had to be fully knowledgeable in. And that was the specialty. And so so we sort of developed a core of each of those problems that emergency physician should be really knowledgeable about.
Right.
And that's what created that specialty. And so we had specialty training at the time with special surgical techniques, fixing certain fractures, doing diagnostic tests, because that way, we didn't have to call people in the middle of the night. We could do it ourselves.
Sure.
But it grew. But I think what happened is that as the GP's offices got busier, and more difficult to get appointments, and there was just more sort of critical illness, that the emergency department looked like the first place to go to.
Yes.
And that's what happened. And then the thing that really changed was when the transfer payments changed to the provinces from the federal government, and all of a sudden the provincial government had a deficit in terms of looking after health care, because they weren't getting the projected fee transfers, and all of a sudden things are getting cut back.
About what time was this? Was it in the 80s?
That was
or
probably
the 90s?
in the 80s.
Okay.
In the 80s. And so
the funding formula changed, and
Yeah.
it rippled right across Canada.
That's right, and it affected us in the emergency department, and we're still seeing that sort of effect where we've got a backlog in the emergency department. We can't get beds. We can't move people out of the emergency to make room for new patients. We've got patients in the hallway. We've got ambulances waiting at the door. I mean, that problem is still there, but
Right.
that was what led to my frustration in staying there.
Okay.
And it was at a particular time, I can remember very clearly. It was a Saturday night. I was working in the emergency department. At that time, at the emergency department, I was the only one there. So the night shift, I was one physician.
And on a Saturday night at
On a
Royal
Saturday
Columbian
night,
Hospital, you
that's
would
right.
be one busy doctor.
I was. And so you were. And you had the walking wounded, you had the really sick people, and the trauma. And it used to work because before we could stabilize a patient maybe 1 or 2 hours, and they'd be admitted into hospital
Sure.
under the care of the consultant of the surgeon or the orthopedic surgeon. Now they were stuck there in the emergency department, and I was stuck looking after them all, besides looking after all the walking wounded patients and the other problems. So this one young 17-year-old traffic victim came in at 11 o'clock, 10:30, 11 o'clock on the Saturday night. And she was badly injured. She had multiple fractures, big bone fractures, and she was paraplegic from a spinal injury as well. And we stabilized her, and I was on the phone all night there were no beds in our hospital in the acute care, in the intensive care. There's no beds at St. Paul's, no beds at VGH, no beds at Burnaby. And I was on the phone all night trying to get her somewhere to stabilize her.
Sure.
And to take care of her and to get the ultimate best therapy for her treatment for her injuries. And it wasn't until the next morning at 9:30, I was basically on my hands and knees to a first-year resident in the ICU at VGH, and finally he said, okay, I'll take her. And I got home that day. My shift ended at 8 in the morning. I didn't get home till 11 o'clock. And got home, and I told my wife, I said, that's it. I'm tired of being caught in the middle of things that I don't have any control over.
Right.
I mean, if they just asked me to look after the problems, I love doing that. But this problem of dealing with situations that make me completely uncomfortable has got to stop. And so that's what happened.
Could that be defined in some strange way as the politics of healthcare? And I'm not talking about government, but just the way governments interact with the medical and healthcare providing community. And so we end up with things like rationed healthcare. And I want to ask you more about that.
Yeah.
But there's a lot of politics in the business.
Yes, it is. And it's a very difficult problem. And as you know, we still haven't solved the problem.
Right.
And there's all kinds of possible solutions for it. But at that point in time, that was my sort of limiting moment. And so I started talking to my colleagues and asked them how they felt about it. And there's, out of the 8 or 9 physicians at that time, 4 of us decided to say that, 5 of us, I guess, 5 of us decided that we'd had it. We'd had enough of the overcrowding and the situations where we were uncomfortable. We had enough of the night shifts, and so we decided to leave the emergency department and start a sort of a new concept. Just like we entered, we looked at a new concept of urgent care clinics, not really a walk-in clinic that people are aware of now,
right?
But sort of one that was sort of designed on the sort of a small, less acute emergency department. So we had a suture room, we had a cast room, we had small cubicles to sort of see the walk-in wounded, to move them along, and so we did. We opened our first urgent care clinic in Langley. And
what year would that have been?
That was probably 88, 89.
Okay. An urgent care clinic.
Yeah.
Okay.
And so then we and that worked out really well, actually, and but it did really also redefine the emergency department. And I remember the hospital then took a strong step in terms of looking at how the emergency department was going to develop over a longer period of time. And so
the hospital had no choice, given the fact that they lost so many of their star players.
That's true. And so that sort of led them to look at, say, okay, how can we make this better? How can we solve this or make it better so that we can keep these key people in the hospital? So we did have a very good weekend. They had a sort of facilitated meeting with a professional facilitator to look at the problems, look at solutions, and then determine how the emergency department will change. And so now we're looking at, the emergency department now has 50 doctors. We had 9 doctors.
Right.
We have, they're on salary. We were on fee for service. They've developed protocols and things that make it a lot better to work there. They've got more physicians working at a time, and you've got relegated areas that you've got definition over. You've got a trauma team that comes in once the patient is stabilized. The trauma team comes in and takes over, so the doc that's in the emergency department doesn't have to worry about that anymore.
Right.
So all these new things have developed since then, and for the good. There doesn't mean that they still don't have problems. They do, but it's certainly for the good of the department. But that was where I sort of changed course.
Well, and a great point to get you to just park it for a second, Dr. Zickler, because I need to take a break. And this is a tremendous story, and you've got me completely engaged here. So we'll take a quick time out. Our guest from YesWellness.com is former emergency room physician, Dr. Paul Zickler, who, along with his colleagues, as you're hearing, has redefined the way emergency medicine is practiced in British Columbia, particularly here in Greater Vancouver. This is Boomer Life on CIL 650, and we're right back after this quick timeout.
Celebrating the baby boomer lifestyle. This is Boomer Life on CIL 650.